My name is Dr. Brian Halbert. I am a practicing medical oncologist specializing in genitourinary cancers at the Gail and Tom Benson Cancer Center right here in New Orleans. Absolutely thrilled to have three fantastic speakers here today. Really, our goal is to touch on a variety of genitourinary cancer topics, really highlighting how we can use novel technologies to really help patients in our clinics today. Before we get going, I do need to send a special thank you to Chad Landry and to the entire CAGLA board. The work that CAGLA does to enact real and meaningful change for our cancer patients in Louisiana is inspiring and is frankly critical for the health of our state. Also want to thank you all for being here. CAGLA, by hosting this conference and bringing all of us here together underneath this roof, really it can only bring more projects, more ideas, more collaboration, and more legislation to help the cancer patients here in Louisiana. We've got three fantastic speakers here today, but really the stars of all of this entire conference is all of you out here today too. So really thank you all. The real reason why we're here is for the ideas that we can all bring from this conference, and we can enact, and we will enact together to help improve cancer care here in Louisiana. So without any further ado, I'm going to get our first speaker up here. We have Dr. David Einstein. Dr. Einstein, originally from Silver Springs, Maryland, initially went to Yale University for his undergrad before moving up to Boston, where he got his medical degree and his internal medicine training at Tufts University. Later went across town to Beth Israel Deaconess Medical Center, where we first met, for his medical oncology fellowship, where he continues to practice today, specializing in genitourinary cancers. He is the head of genitourinary clinical trials at Beth Israel Deaconess, and he's an assistant professor of medicine at Harvard Medical School. He's an active member of the Dana-Farber and Harvard Cancer Center, where he works as PI on a variety of clinical and translational projects. He's also got successful funding through a variety of governmental, foundation, and industry grants. Dr. Einstein's also a fantastic clinical educator. As I can attest, he regularly astounds his fellows with his encyclopedic knowledge of GU cancers. No, Dr. Einstein really is that triple threat that so many of us wish to be between clinical care, research, and education. So, Dr. Einstein.
You're going to be sorely disappointed after that intro. So I guess I'm an expert in genitourinary things, if that's what we're calling this. But I'm really happy to be here. Huge honor. Thank you for welcoming an outsider into your midst. Great to be here from Boston. I'll kick things right off by just saying I don't have any disclosures relevant to this particular presentation, other than my very sordid past in trombone playing before my medical career, which led me to a particular attraction to your conference that's got that right on its website. So I was tasked with the gargantuan project of reviewing all of GU medical oncology in the last year. There's been so much, especially this year, so we clearly won't have a ton of time to dive into each one of these trials. But what I'm going to do is try to summarize some high-level data. I'm going to use that as a springboard into kind of critiquing or seeking to understand trial design and what questions these do and don't answer. And then also try to provide some clinical anecdotal experience for anyone starting to use these in their own clinics, and certainly welcome everyone else's experience as well. So we'll kick things off with probably the least clear area of all, which is what I affectionately call the Wild West of prostate cancer, or biochemical recurrence. So this, of course, refers to a patient who's gone through primary therapy, be it surgery or radiation, plus or minus local salvage therapies, and continues to have a rising PSA. And it's kind of a micrometastatic or pre-metastatic state, but one with a very, very heterogeneous natural history. Some people can live for the rest of their lives with a rising PSA and nothing ever comes about from it. But in other patients, it can become a problem. And so we actually don't really have a clear treatment paradigm for this situation. We've got the option, of course, of starting hormonal therapy, as some folks might do intermittently. We also have the option of deferring that until someone develops metastatic disease. And we actually don't know which one of those pathways is better. We've got one randomized trial that attempted to address that question and didn't find any difference to early start of ADT. And in fact, the NCCN guidelines recommend against use of ADT in this setting, even though it's quite commonly done. So just to sort of think about the idea of looking for those patients at highest risk, which we oftentimes do based off of the PSA velocity or doubling time. This was one of several reviews out there looking at data retrospectively and trying to answer that question of, what is the natural history? What do we mean by high risk BCR? So these are patients who, after BCR never got hormone therapy until metastatic recurrence. And what they found here was actually that the natural history of even patients with PSA doubling times of less than 6 to 10 months is incredibly long. I mean, we're really talking about years and years, even sometimes decade of life without metastases, let alone overall survival. And so in this particular study, they were looking to put this up against some of the trials that had been done in non-metastatic castration-resistant disease. But I think really these data alone are quite interesting when we start this conversation about treating or not treating quote-unquote high-risk BCR. So into this very unclear setting, we insert the EMBARK trial, which was taking patients with PSA doubling times of less than 9 months. And importantly, this is being done in an era of conventional imaging. So they have no metastases per conventional imaging, intact testosterone, and minimal prior hormonal therapy. And they're being randomized between combination ENZA and ADT, ADT alone or ENZA monotherapy. And if your PSA got to undetectable at 3/4 of a year in, then there's a treatment break, and then you reinitiate treatment at a predefined threshold. And so the primary endpoint here was metastasis-free survival based off of conventional imaging. So taking a step back, I always like to think about, what is this trial really trying to ask? And so, if you're old, if one of your old standard of care was to start ADT for BCR and later add enzalutamide for non-metastatic CRPC once the PSA started rising, this trial instead is sort of bringing that forward and asking, what about ENZA with or without ADT early on? Importantly, what it doesn't test is a surveillance strategy followed by aggressive hormonal therapy at time of metastatic recurrence. So the patients in this trial kind of spread across the very fast doubling times to longer. And I think one important caveat here is that there's about 1/4 of these patients who've only gotten surgery, and that means they've never gotten curative intent salvage radiation. Now, in theory, by the protocol, you were supposed to not be if you were eligible for salvage radiation, you weren't eligible to get on this trial. But in reality, how common are those patients, right? If you're eligible for a clinical trial, there's very few of those people who would not be eligible for salvage radiation. So I emphasize that mainly to just say, let's not get dazzled by the new and skip over the old things that can actually cure patients. So these are the top line results here. Metastasis-free survival with the combination of ENZA plus ADT beats ADT alone. Probably not terribly surprising, but maybe a little bit more surprising was actually that ENZA monotherapy beat ADT alone. And that kind of raises the question of whether using ADT as the backbone, as the starting point of all of our systemic therapy is really the right approach. Maybe we've been getting this all wrong just based off of history, and maybe AR antagonists are probably the most potent agent here. I think one other thing that we want to think about, even though this is all hormonal therapy that all of us are very familiar with, we're looking at about 1 in 5 patients on the ENZA-containing arms discontinuing treatment due to AEs. And so that's a pretty notable discontinuation rate. We really have to think about these patients as not being metastatic patients. They're really just dealing with a rising number. And so that becomes a very difficult sell if somebody's really experiencing a lot of toxicity. So I'm going to walk you through a somewhat complicated figure here from an opinion piece that's under review. And essentially what I'm trying to do here is compare this EMBARK strategy in red with a surveillance strategy that was not tested on that trial, but is still a very reasonable standard of care. And so if you think about the EMBARK strategy in red here, so you're going to start ENZA for rising PSA, you're going to suppress the PSA, at some point you're going to take a break, PSA is going to rise again, you're going to reinitiate, and so on and so forth, although of course you're going to get some diminishing returns, and at some point probably going to need to add in the ADT. In contrast, in blue here, we've got a patient who's got rising PSA, nothing's happening for a few years, then might develop metastases, at which point we start combination therapy. So clearly, the red strategy results in a much longer metastasis-free survival. That sounds good, right? It's good to be without metastases. But I think of that as sort of a trade-off between that and what we call treatment-free survival, which is kind of a novel patient-centered endpoint that's been proposed in kidney cancer and melanoma. The idea being to really quantify the amount of time over many years that patients are spending on treatment with the toxicities thereof and the certainly financial toxicity as well. So clearly the red strategy results in a lot less treatment-free survival. And the big question here is, what's the difference in overall survival, which we don't know yet. That's a secondary endpoint. So I think that all this bears very careful conversation with a patient, and certainly not a quick recommendation simply to pull the trigger on systemic therapy. Okay, so now we're going to transition to a later disease space in castration-resistant disease. This has been a subject of a lot of conversation in the GU world over the last year or so. So here we're going to talk about androgen receptor signaling inhibitors plus PARP inhibitors. So as probably many people are familiar with, we have these DNA damage repair or homologous recombination repair alterations that we've been now doing sequencing in all of our patients looking for these targetable alterations. And we know from prior data that olaparib seems to demonstrate an overall survival benefit, especially in those patients with pathogenic BRCA2 alterations. Unfortunately, that's a small subset of our patients, and so certainly some of these data don't apply to the vast majority of patients walking in our door. We also know that even for those who do have BRCA alterations, that's not a perfect biomarker either. And we know that outside of BRCA, the data become very murky, and so that becomes difficult. So this is just looking back at that initial PROfound study that got olaparib its approval. And what they showed, of course, they were binning together BRCA1, 2, and ATM alterations in this cohort A. And that's the cohort where they saw a very significant survival advantage compared to ARSI switch. For the non-BRCA alterations, which you have to dig into the supplement for, there wasn't as clear a benefit, but again, a lot fewer patients in these groups. We've since learned that ATM is probably really not a good biomarker for PARP sensitivity. So most of this, if not all of the benefit, is really driven by BRCA1 and 2. And this is just a forest plot summary of all of those data. So if your old standard of care was to do some systemic therapy and then think about PARP inhibitor for a select group of patients at the time they needed their next line, the next set of trials is going to ask the question of bringing PARP inhibitors forward in combination and seeing if that's any better, and also seeing whether that expands the benefit, whether there's any synergy that results in a broader patient population being eligible. So this is the PROPEL trial, and this took patients in first-line CRPC and randomized them between abiraterone with or without olaparib. And the primary endpoint here was radiographic PFS. So these are the top-line data here. They're showing us first the non-mutant subgroup. I'm going to use the terms HRR and DDR interchangeably, but obviously we have to dig into exactly which genes these are. So here's where there seems to be a fairly significant benefit with a hazard ratio of 0.76 and upper bounds of the confidence interval that does not cross 1, but even much greater in the HRR mutant group with a hazard ratio of 0.5. Okay. Here's a second trial very similar to that, although in this case they actually prospectively looked at genomic alterations rather than retrospectively. And so you had to have these results available, and the randomization was done based off of those results. Okay, so we've got an HRR positive group, we've got an HRR negative group, and each is being randomized between abiraterone with or without niraparib. So here on the left here is the BRCA1 and 2 groups. Unsurprisingly, that's where the big difference seems to emerge. Okay, in other, if you lump all the HRR alterations altogether, there is still some benefit, although it becomes murkier. And so this is just a forest plot, again, suggesting that we're most confident when it comes to BRCA. And unfortunately, the HRR negative cohort was actually stopped for futility. And then finally, TALAPRO-2, also done in first-line CRPC, is taking patients who are either unselected or specifically DDR altered and randomizing them to enzalutamide with or without talazoparib. And here too, they show us all of the patients all together and a separation of curves, but then diving into the different biomarker groups, for those patients that are HRR deficient, there is a clear separation of curves here. Whereas for the non-deficient or unknown, there is still a separation with a hazard ratio of 0.7 and upper bound of 0.89, but clearly less of a benefit. And this is, again, just a forest plot summarizing that, where we really are most confident for the BRCA alterations. There seems to be some benefit for the non-deficient patients. For the unknown patients, which is a sizable subset, there's not a lot of confidence there. So this resulted in several FDA approvals for patients with BRCA alterations, the combination of abiraterone with olaparib or niraparib, and then for patients with HRR alterations, as defined by this long list of genes, you could get enzalutamide and talazoparib. Okay, so what do we think about all of this? Well, I think the first thing is to make sure this patient population exists in your clinic. So in my clinic, the idea of patients coming in relatively naive to ARSIs in first-line CRPC is quite rare these days. It really implies that you've gotten ADT alone for metastatic disease or for BCR, and that's just a very small patient population for me. You look in the trials, and the patients enrolled in these studies, really a very small percentage of them have ever gotten ARSIs before. So this is a less resistant group than what's walking in my door in first-line CRPC. So this doesn't exactly apply to the patient that I'm seeing who's already been on ADT and ABI or an AR antagonist for several years and now is progressing. So there's thought that we may actually need to repeat these studies in a more modern patient cohort. The other big question is thinking of this as not just a trial of new versus old, but really a sequencing trial, right? It's trying to bring something that we used to hold on to for later and bring it earlier. And in that case, we need to make sure that the control arm actually gets what we think is the standard of care, okay? So if you actually try to dig out the information about patients with HRR alterations and see, did they in fact get PARP inhibitors after the trial was done? Well, it turns out, first of all, it's very hard to get those data. They're oftentimes buried in the supplement, or you have to look at an abstract. So these were sort of numbers that I've come up with, but they're constantly changing depending on where you look. The take-home message here is that they're small, right? And so I think that this really concerns me that the benefit that we're observing may be in simply guaranteeing access to PARP inhibitors to patients who should be getting them at some point in their lives, and not guaranteeing access for the control arm. And that's particularly an acute problem in patients in low and middle income countries where it simply may not be available as standard of care. And so I think that's also a message to sponsors out there of thinking about crossover and sort of guaranteed access after progression. Finally, there's going to be several trials looking at these combinations in an even earlier disease space of hormone-sensitive disease, and so we may be pushing these ever forward. So in reality, who would I offer this to? Well, first of all, it would have to be a patient who had developed CRPC in the context of ADT alone, which is quite rare in my practice. I think I'm by far most confident with BRCA1 or 2 somatic or germline alterations. And I'd also talk about that endpoint of radiographic PFS and say that you're really having to be motivated to do something to delay a scan from getting worse, as opposed to improving quality of life or improving overall survival, which are the things that we really care about. And clearly there's more toxicity from spending more time on those treatments, albeit manageable. So I will say in reality, I haven't used these combos, but I'm curious to see if others are using these, and if so, in what patient populations. Okay, so now we get to turn a little bit to bladder cancer and kidney cancer. We'll leave prostate cancer behind for a moment. And in bladder cancer world, this is a figure that I had come up with for the ASCO SEP chapter that gets distributed to at least our fellows. I'm not sure about yours. We're constantly having to update these figures as all these new data come in. And so in the typical strategy for advanced urothelial carcinoma, we would start by thinking about whether a patient was cisplatin eligible. If they were not, by virtue of CKD, but otherwise had good performance status and were still chemo eligible, then we would think about carbo-based regimens. And then, of course, some of our patients have performance status or comorbidities that really don't permit chemo whatsoever. So for the chemo patients, we would start with chemo, some sort of platinum-based doublet, usually a platinum gemcitabine. And then based off of response, we might consider a maintenance avalimab strategy. Alternatively, you might reserve your PD-1 or PD-L1 inhibitor for your second-line therapy. And then for patients who couldn't get chemo, clearly there was no option of getting chemo, so they would go straight to PD-1. And then in the second or third line setting, we would start thinking about erdafitinib for people with targetable FGFR alterations. We would think about some of our new antibody drug conjugates, or mostly historical, at this point, single agent chemotherapies. So into this space, the EV302 trial was testing whether a novel combination of EV and Pembro, how that would do against chemo. And I think importantly here, both EV and Pembro are already in our armamentarium at this point, but they're not being used together, and they're being used as second and third line therapies. So these are patients who are previously untreated. They are eligible for all of the drugs involved. Importantly, they have GFRs that are 30 or above, so that is fortunately including a good number of our patients, although not all of our patients, and decent performance status. And so they're getting randomized between EV and Pembro kind of indefinitely, right? So this is maximum of 35 cycles for the Pembro, but it's essentially until it's intolerable or progression, versus chemo for a maximum of 6 cycles. And they have dual endpoints of both PFS and OS. And looking at the patient population, I think the important thing that I wanted to point out here was just that about half of these patients are cisplatin eligible. And I think that's important because that's probably the clinical reality, right? So many of these patients have CKD or various comorbidities preventing us from using cisplatin. And a good number of people with visceral mets, which is just a higher risk category. So if our old strategy here was chemo followed by PD-1 followed by EV, we're now asking the question of flipping that whole paradigm around and using later line things together, and then question mark afterwards. We don't really know what to do there. So here's the top line result, which was really just one of these big splashy headlines for good reason. I mean, just a dramatic difference in overall survival. No subtlety there at all. And that was importantly maintained whether or not you were cisplatin eligible, because there's this idea that cisplatin confers the potential for kind of long-term responses in a subset of our patients, and so maybe we shouldn't sacrifice that opportunity. But really, this doesn't suggest that we're doing people any favors by giving cisplatin first. The forest plot is small here, but the message is everything's way over to the left side, favoring EV Pembro. AEs are important too, and I think that there's this idea in patients' heads sometimes that if it's not chemo, it's definitely going to be easier. I definitely do not believe that. I think that in my experience, fatigue has been, as shown here, at least equivalent, if not sometimes worse, with the EV. But I also think it carries some unique toxicities that we're still getting our hands experienced with. So the key overlapping toxicity here is skin, right? Because both of these have that. And so it's sometimes difficult to distinguish what's what when the patient comes in with rash. I think that the time course is very helpful because a patient who comes in for cycle 1, day 8, or cycle 2, day 1 with a new rash, it's very unlikely to be immune related at that point. It's not impossible, but it's more unlikely. And so that helps me think a little bit about what I'm going to do with my treatment. I will say that fortunately at grade 1, the treatment is similar, if not the same, between both of those strategies, where we give topical steroids, or in some of the patients with EV who get kind of a dry skin manifestation, we give simply moisturizers, emollients. And at BI, we're starting to set up an oncoderm clinic, and we are developing an SOP for managing these patients. So we're very fortunate to have a dermatologist who will see them quickly, but I think it's also important to kind of have a plan ahead of time so that all of us can kind of practice in a uniform fashion. So neuropathy we're all familiar with from cisplatin days, but I think that in my experience this has been probably even more problematic with EV. And part of that may be just the fact that it's generally given until progression or intolerance, which is a lot different from how we usually give cisplatin. So what I've generally been doing is being very aggressive about early dose reductions, because what I'm worried about is the patient who I push a little bit too far, then I'm going to have to take a prolonged treatment pause in order to let that resolve, because it takes so long for neuropathy to improve. And so at the earliest signs of that happening, I really start thinking about backing off on my dosing so that I don't have to end up in a situation where I'm off of treatment for many months. But I think we have so many questions about this and lots of interesting work for us to do, both observationally and in the trials world, about how long do we truly need to give the combo? Could we de-escalate? For example, could we give a limited number of EV cycles and then have sort of a pembro maintenance strategy? What about in the neoadjuvant setting? Well, we actually have trial data that are going to read out in a typical neoadjuvant setting, and so stay tuned, and we'll see whether we're still giving dosed Enzemvac in the future. But I think in our clinic, we've had a number of patients recently walk in with node-positive disease who are kind of in this gray zone between localized and metastatic, and we really debate what to do there. We can have a long debate about that in the Q&A, but I think what we've been starting to think about is node positive is probably really best treated as a systemic disease, and therefore we should use our best systemic therapy. So we've started using EV Pembro there. It's not exactly per label if the patients are potentially resectable, but we can sort of call them potentially unresectable and then see what happens. And then so for the patient who has a really good response to that, we can then think about consolidative local therapies like surgery or radiation. But in the patient who unfortunately has primary progressive disease, that's probably a situation where we didn't want to think about local therapy anyway. Okay, so finally I'm going to turn to kidney cancer. I'm actually going to skip the probably biggest story, which is the adjuvant pembrolizumab story, which I'm happy to talk about more in the Q&A. But I wanted to maybe transition a little bit away from sequencing the old therapies and think a little bit about a new therapy, since in kidney cancer world, unlike prostate cancer world, we've had kind of a limited number of different types of therapeutic categories. We've had checkpoint inhibitors, we've had VEGF TKIs, and that's about it. So this is the LIGHT-SPARK study, and this is a test of belzutifan, registration trial of belzutifan, which is a HIF-2 alpha inhibitor. And this is based off of actually Nobel Prize-winning work out of the Dana-Farber Harvard Cancer Center, Bill Kaelin's lab. And this is a lot of work to do with how kidney cancer is driven by kind of alterations in von Hippel-Lindau and activation of this kind of hypoxia sensing equipment of the cell. And so belzutifan is going after that sort of overactive HIF activity. And in this trial, they're taking patients with advanced clear cell kidney cancer. They had to have at least prior PD-1 and at least one VEGF TKI. That could have been in combination or separate. And they're being randomized between belzutifan and everolimus. Now, there's a lot of criticism about this control arm, right? Everolimus might be thought of as kind of a toxic placebo. It had previously shown some benefit versus placebo, which is why they justified doing this. But many of us in reality might think that a better control arm would be VEGF TKI switch, because many of us would basically never use everolimus as monotherapy. So here are their primary data for PFS. And what you can see here is clearly a separation of curves out back here, but unfortunately kind of a steep drop-off in both curves early on. And so, and this kind of mirrors my clinical experience, where some patients, especially those with kind of explosive disease, progress straight through. But if you get to your first or second restaging scan and are in good shape, then there may be kind of a plateau there, sort of, where you sort of get to a stable disease point. I will say we haven't seen a lot of dramatic responses on the patients on the clinical trials of this, but a good number of patients with stable disease that's maintained across many months and sometimes even years. The OS data were kind of disappointing, especially compared with that kind of inactive control arm. And I think that clearly these data are immature. There's a lot of censoring going on out here. So more time will tell whether this slight difference here might emerge as a more significant one. I think there's hope that it might, but I think there's more hope that moving this earlier might be more helpful. So at the moment, we can use this for patients who have progressed on PD-1 and VEGF, and that could be as a combination in the first line or sequential. As I said, I don't think that this is going to be great for salvaging rapid symptomatic progression. And I also want to point out that cost is not insignificant for this drug. And we always talk a little bit about cost, but in particular here, where we're used to thinking about, upwards of $11,000 to $13,000 a month for AR antagonists and such, or I think $15,000 for cabozantinib per month. This is listing for $35,000. It's just astronomical, probably unsustainable. AEs are interesting for this drug. It's actually a very easy drug to give for the most part, but I think there's a couple of important caveats and a little bit unfamiliar if you haven't been using this. So the first thing is anemia. Anemia is an on-target effect, and so we get very familiar with using or supporting people through that. I always get a baseline ferritin because I'm preparing myself for the need to use erythropoiesis-stimulating agents. And if I start seeing a hemoglobin drop, I'm pretty aggressive about starting those because with that, we're actually able to avoid the need for dose reduction or holds. So you can treat straight through with ESA support. Hypoxemia is also an interesting one that I haven't gotten any good explanations for what the mechanism is here, but we've seen this especially in people with underlying lung disease. Sometimes symptomatic, sometimes asymptomatic. Fortunately, the half-life is quite short, so you can hold it and get rid of that fairly quickly, and we have been able to successfully re-challenge people with dose reductions. So there's a lot of future development of this drug, both in the advanced setting and also now as adjuvant therapy with kind of the PD-1 backbone. And I think that summarizes the wide world of GU cancers for 2024 in a half an hour. And so hopefully you got something out of that. But I'd say that even going beyond those top-line messages, I think there's a lot to be excited about in GU oncology. I find it fascinating based off of all the different treatment types that we get to use. I also think there's plenty of room for skepticism, and I think that when we read these registration trials, they're really answering one question, which may not be the question that we need answered when we're sitting in front of a patient. So we have to be very careful about how to read these. I'd like to advise everyone when they're reading this to zoom out and sort of think about it as that algebraic equation. Is this a new therapy, or is it moving a new therapy, or moving an existing therapy earlier? If it's moving an existing therapy earlier, does the trial include the true standard of care? Does your standard of care arm actually have access to the drug that you're moving earlier? Does the population fit what we think of as standard of care in terms of what they've had previously? And then finally, is our endpoints like PFS truly meaningful if we're simply moving things forward? I would argue that no. If you're moving things earlier and then checking PFS after that, that's actually irrelevant. What you really care about is what happens at the tail end, when both groups have had the same exposures. So with that, I'll thank you very much for your attention. Thanks so much for having me down here. Happy to take questions during the Q&A, and I'll turn it back over to Brian.